You're all very welcome to this another edition of MUS UCAM webinars. I do hope that you are all enjoying and gaining the fruits of these webinars as much as we as presenters. I mean, we are also learning with every webinar that we are preparing. It's a great insight into how small things are also coming to our notice. And we're very happy that you all choose to join and be our partners in this massive musculoskeletal ultrasound crime, which we hope that will have its own place under the sun very soon. And I'm sure with every you, we will. And I'm going to, Mohit is no a new name to any one of you. He is also now, he has taken over the strong reins of being the president of the society. And he's taking over a very important topic, which is the um, developmental dysplasia of hip joint, which used to be called as CDH earlier. And what I am lately seeing, and I'm sure each one of you will be observing, that the obstetricians and the pediatricians have become extremely conscious that if it's a breech baby, if it is a firstborn, and if it is a girl, I am routinely getting ultrasounds just to rule out DDH. Just to rule out. They're not having any positive signs, but they ask us to rule out DDH just in case. So it's very important that each one of you and each one of us also have a revision as to when is the optimum time, when is it that it stops giving us the benefits, and if done early, what are the negatives? And so Dr. Mohit Shah is going to give this presentation and enlighten us on this very wonderful topic. Mohit, the floor is yours. Go on.
Yes.
Thank you.
So good evening, everyone. I will just briefly share what I have learned over the years. I had the good fortune of actually attending the Graf's course when Professor Reinhard Graf was in Goa in 2005. So actually, that was the stimulus for me to start the ultrasound evaluation of the pediatric hip. And if you actually look at it, it's actually a mind game. You know, you are too scared to actually do it because you get confused between alpha and beta angles and the types and subtypes, which I think for a beginner is scary till you understand what they imply, what are the basics and fundamentals of a developmental dysplasia. I think once you understand that and you put it in place, it is much more easier. And as Nidhi rightly said, you know, the clinicians are getting aware, but we still do not have a very robust program to screen all babies delivered with bleach or all babies which are delivered, which actually Professor Reinhard has that in Austria. In Austria, all babies delivered undergo a hip screening, and therefore their pickup rate is much higher. So when we talk about developmental dysplasia, it's one of the most common problems, musculoskeletal problems, and it was formerly known as congenital hip dysplasia. But now we have to understand that it is DDH and not CDH, which stands for developmental dysplasia of the hip, because it's a developmental disease. I mean, you have to understand that there are children who are born with normal hips who later develop dysplasia. On the other hand, there are children who are born with dysplasia of the hip, but that can resolve spontaneously or after relatively simple treatment like a Pavlik farners. So you have to understand that it is a dynamic disease and it is not always present at birth as suggested by the name CDH. And therefore that term from congenital got replaced to developmental because it's quite a dynamic disease, but the treatment is easier and complications are less likely to occur when it is diagnosed early. There are a lot of theories and etiology, but we have to understand there are definite known risk factors and inadequate intra-uterine space due to any form of oligomnias, more common in females, more common in multiple gestations, again because of too much of crowding, breech presentation, positive family history also plays a role. But most importantly, club food was thought to be a risk factor, but this no longer holds true. We used to have initially cases all club food coming for developmental dysplasia evaluation. And an untreated DDH or an undiagnosed DDH is a leading cause of osteoarthritis of the hip joint. Some statistics, if you want it, its prevalence is 1 in 1,000, more girls than boys, more in girls with breech position and in girls with positive family history. It's much more commoner on the left than the right. Hip, you have to understand, is a ball and socket joint, where the femoral head is the ball and the joint, the acetabulum is the socket there. And this is stabilized by the surrounding joint capsule and the ligaments. But what is most important for you to understand is the reciprocal development of the femoral head and the acetabulum. This is a quite basic yet the most important concept of DDH, that the concavity of the acetabulum develops in response to the presence of spherical femoral head and vice versa. Means that the concavity or the hollowness of the acetabulum will develop only when it has that spherical femoral head occupying that space, filling up that joint space, and vice versa. So what that means is that if the head is not properly located, neither side of the joint will develop normally. So if the head is dislocated, for example, then the acetabulum will always remain shallow and the head will always remain deformed. And this is the meaning of reciprocal development of femoral head. So for both sides of the joint to develop normally, they need to be coherent with each other. The femoral head should well be within the joint for the acetabulum and the femoral head to develop, because this concept has profound implications for treatment of cases where diagnosis gets delayed simply because the joint cannot relocate, as the misshapen head may not fit in the shallow maldeveloped acetabulum. It will keep slipping out, and eventually this patient will end up with bad osteoarthritis and a massive dislocation of the femoral head. Well, the presentation of the patient depends purely on patient's age. We need active surveillance programs in a country, but yet we do not have. So whenever we do get references, it's basically because the clinician suspects it. Because the problem with DDH is that the hip does not hurt, so the child will not keep crying. And because the child is not expected to walk, the parents won't notice it either. And this is the bigger dilemma. And therefore, it is imperative that the clinician or the attending physician in the labor room looks for DDH, suspects it, and sends it for evaluation. When the child grows of walking age, there will be an apparent leg length discrepancy or limited abduction movement, and that will be the first sign that there's something wrong with the hip. When it concerns bilateral dislocations, the patient may have limited abductions and they will walk with a waddling like a duck-like gait, and that should raise a suspicion of bilateral DDH. So before I delve into imaging, I thought it is prudent that you understand that there are two clinical tests which we can use for screening, which are used for screening rather, Ortolani and Barlow tests. They're both performed on a supine infant. The Ortolani test reduces a dislocated hip, where the Barlow test attempts to dislocate an unstable hip. So I am stressing on this clinical test because we use the Barlow test as a dynamic maneuver to test for dislocation or subluxation of the hip. But we have to understand that by 3 to 4 months of age, the soft tissues tighten and the Barlow and orthologies cannot be then perform so effectively. So if the patient is an infant, if just delivered, you can still perform both these tests, and it is simple to perform. In ortholani, in a supine infant, we flex the infant's hips and knees and apply pressure anteriorly. So test is positive if a clunk is heard as the femoral head is relocated in the acetabulum. Whereas now this is Altulani, this is what we do. We push the thigh interiorly, and the reduction is done by abduction of the hip and pushing the thigh anteriorly. Just abduct and push anteriorly, holding the greater trochanter, pushing it anteriorly, and the dislocated hip will slide back into the socket. The Barlow is exactly the opposite. For the Barlow, we apply posterior pressure and on an adducted hip so as to subluxate or dislocate. Again, you will hear a chunk when the head gets dislocated. So exactly opposite of ortholani, we will do that in abduction and by applying posterior pressure. This will make you understand better. This is Barlow, adduct the hip and give a posterior pressure so that it dislocates posteriorly. In ortholani, exactly opposite. What we do is we abduct the hip and push it anteriorly so that it comes back into the socket. So Barlow and ortholani are opposite to each other in mechanism, but the objective again is to check for DDH. There's also one sign called the Galeazzi sign, where if you keep the knees flexed with the palms, with the foot on the table, you will realize that there will be asymmetry of the height of this. And this is called the positive Galeazzi sign. This is because if you have a hip dislocation, you will have a limb length discrepancy, and that limb will be shorter than the normal limb. And this is one more very easy to pick up clinical sign that even before you actually put in the probe, you can suspect that this side would have a DDH. So the imaging modalities, when the plain radiographs always form the primary imaging modality for a clinician. Ultrasound and dynamic ultrasound play an important role. So does cross section. I mean, the CT comes into play when you really want to construct a 3D picture of the acetabulum and the bony anatomy, because this is going to be useful in preoperative patients and also in patients where you need a resurgery or reoperative planning. That's where 3D reconstruction helps the orthopedic surgeon to plan the surgery better. Now, previously, we used to always use the frog leg view to get the plain radiographs of the hip joint, but that is not necessary because you're taking the frog leg view. You're actually increasing the soft tissue and the distance from the cassette, and therefore you're increasing your KV and doubling the radiation dose. So a single AP radiograph now is the most appropriate examination after the femoral head ossification has occurred, especially after 1 year old. Asymmetry of the femoral head ossification center is again one sign where you suspect DDH, because where you have a DDH, very often you will have delayed ossification of the femoral head on the same side. And if there is no ossification of the femoral head, we can still determine DDH by looking at the relationship of the proximal femur to the developing pelvis. For that, we have multiple lines that we have studied as radiologists: the Hilgenrenner, the Perkins, the Shentons, and the acetabular angle. So I shall discuss the top four because they are easy to draw and easy to interpret. So that's the pelvic X-ray there. You see this ossification. Both sides femoral heads are ossified. So obviously this child is more than 1 year old, but you see that the femoral head on the symptomatic side is much smaller than the normal side. You see the acetabular angle. You see the shallowness of the acetabulum on the abnormal side. You find that the femoral shaft and the femoral head are much more laterally placed. So how do you put that objectively? This is good subjective evaluation that the left femoral head is dislocated. I can easily buy that, you can easily buy that. But how do we objectify this into proper DDH? So we know the Hilgen-Reynolds line, which passes to the triradiate cartilage, horizontal line which passes through the triradiate cartilage between the pubis and the ileum, ischium and the ileum. And then you have the Perkins line, which is a vertical line drawn along the lateral aspect of the acetabulum. So the Hilgen-Renner and Perkins intersect each other, and at the level of the hip joint form four quadrants there: inner inferior, inner superior, outer superior, outer inferior. Then you have the Shenton's line. The Shenton's line is drawn as a semicircle along the inferior aspect of the neck of the femur, and it is coherent with the inferior aspect of the superior pubic ramus. So this forms a perfect circle if you draw it from the inferior part of the neck along the inferior aspect of the superior pubic ramus. So the Perkins-Hurgil-Inner Shenton's line and the acetabular angle. So the acetabular angle is the angle drawn along the roof of the acetabulum, and the angle it makes to the Hilgen-Reynolds line. Normally, it is less than 30. If it is less than 30, means yes, the acetabulum is developing well. And now when you compare that to the abnormal side, see the normal side, you will find the femoral head, which lies within, the lower medial quadrant, that is inferior to the Hilgen-Reynolds and medial to the Perkins. So the innermost inferior quadrant, you will find the femoral head there, and that is a normal location for a femoral head. If you look at the femoral head here, you will find that the femoral head is displaced, and now it lies in the superior outer quadrant, that is lateral to the Perkins line and superior to the Hilgen-Reynolds line. So this is a very classical feature of a displaced hip, where the femoral head, instead of lying in the lower inner quadrant, is now lying in the outer superior quadrant. If you also look at the Shenton's line, because the proximal shaft of femur is now dislocated, the Shenton's line is broken. You see the dotted green line? It does not form a semicircle anymore. It is broken because of lateral displacement of the proximal shaft of femur. And if you look at the acetabulum, this is more oblique and more shallow. And therefore, when you plot the acetabular roof angle here, you will find that it is more than 30 degrees. So radiographic evaluation suggests an femoral head which does not lie in the outer, in the inner lower medial quadrant. It can lie anywhere other than that. You will have a break in the Shenton's line, and you will have an acetabular roof angle which is more than 30 degrees. Ultrasound plays a pivotal role, and it is actually the most diagnostic imaging modality in the first 6 months of age. Beyond 6 months of age, the head starts ossifying, and that's when it will cast a shadow, and you will not be able to appreciate the deeper anatomy. So, but for infants younger than 6 months, ultrasound remains the imaging modality of choice, because it can evaluate both bone as well as cartilage elements in the first 6 months. It can look at the morphology of the iliac bone, the shape of the acetabulum, the bony roof, the cartilaginous acetabular rim, and the coverage of the femoral head by the cartilage of the acetabulum and the labrum. But it can also help you do a dynamic study. And fortunately for us, in ultrasound, we are looking at the same anatomical structures as we see on X-ray, because ultrasound images are also in the proper coronal plane. So to get those coronal images, we will place the infant in a lateral decubitus positions. The hip would be flexed, they would be abducted and medially rotated, and the transducer is placed parallel and lateral to the hip joint there. So this is the way we place the transducer. That's the coronal view, that's the ilium, that's the proximal shaft, and we place it in the coronal section to get a image on ultrasound which is perfectly coronal. So what are we expected to see? Well, this straight line is the iliac bone there. The iliac bone continues as an acetabular roof. This echogenic structure where it ends, where the bone ends, is the os ilium of the, it's a echogenic dot that is the most important anatomical landmark. And below that, you have the triradiate cartilage of the hip. So the last bony part of the acetabular roof is called the os ilium. And the bony rim is where this concavity turns into that convexity. So this is considered the bony rim. Wherever the concavity of the acetabulum turns into convexity is considered the bony rim. That's the acetabular cartilage. And there you have this triangular echogenic labrum. This hypoechoic is a femoral head. You see the tiny dot of ossification that is beginning there. That's the neck of the femur, and this is the anatomy that we see. You have to ensure that the iliac bone is taken as a straight line. The most important feature here is that you have to get this anatomy right. And this was discovered and practiced massively and expanded by the Graf method. So credit should go to Professor Reinhard Graf, an Austrian who has dedicated his life for diagnosing and prognosticating DDH. And he describes the types based on alpha and beta angles. So the Graf method uses alpha and beta angle. So I am going to discuss DDH from a perspective of Professor Reinhard Graf. And as a general rule, by Graf's method, the alpha angle determines the type, whereas the beta angle determines the subtype. So sometimes when it gets confusing, you have these tables there, which you can keep in front and see where the angles lie to understand the subtypes. But even if you understand the types, by the end of this webinar, I think that would be something that would be creditable. So the proper anatomical section is the most important way forward when you actually want to calculate angles. So the proper anatomical section should have three components. One, section going through the middle of the acetabular roof. Second is the lower limb of os ilium. And third, the acetabular labrum. So the lower limb of os ilium is the most important landmark. If you do not see the lower limb, we do not have a diagnosis. You have to get that section where you get all of three, but most importantly, the lower limb of os ilium. So you have to understand that getting this section is the toughest part when you are evaluating for DDH, because the moment you are slightly anterior, your iliac bone will slope up. The moment you are slightly posterior, the iliac bone will slope down. So you have to ensure that you're perfectly coronal, and you can gauge that only when this becomes horizontal to your transducer. When this becomes horizontal, that's the perfect iliac bone that you want. That's the acetabulum, and that's the lower limb of os ilium. This echogenic dot that you see, the most medial part of the acetabulum is called the os ilium. And you see this hypoechoic triradiate cartilage that forms the center of the hip joint. You have the acetabular cartilage there, and you have this triangular acetabular labrum. That's the femoral head, unossified femoral head sitting into the acetabular cavity, and that's the ossified neck of the femur. So the three important anatomical landmarks highlighting that again, the first one is that the line should pass through the acetabulum perfectly parallel to the ilium. Second most important landmark is the lower limb of os ilium. And the third is that echogenic acetabular labrum. Reiterating the fact that if you do not see the lower limb of os ilium, you do not have a diagnosis. You are in the wrong section. You need to get back to the perfect section where you have these three anatomical components. After you have taken the perfect section with the three anatomical landmarks, you have three lines to draw to get two angles. Now, these three lines are the bony roof line, which is tangential to the bony roof. It will extend from the os ilium and go tangent to the bony roof. That's line 1. The second is the cartilage roof line. Now, this is tricky because it passes through the acetabular labrum, but it will join the bone at the cartilage rim. That's the roof line where the concavity becomes the convexity. So you have to follow the acetabular concavity to get the convexity, and that will be the second point of the cartilage roof line. And the third is the baseline. This goes tangent to the upper limit of the straight ilium. So you have three lines forming two angles, which we will discuss in the next slide. The first line is the bony roof line, the second line is the cartilage roof line, and the third is the baseline. So imagine this round is the head of the femur, that's the ilium, that's the bony roof of acetabulum, that's the os ilium there, that medial most component there, and that's the acetabulum labrum. So you draw the first line which is parallel to the iliac bone, and therefore you have to understand that the iliac bone has to be as parallel to the transducer as possible because your baseline extends parallel to the iliac bone. The second line is a roof line which will go tangent from the lower limb of os ilium to the acetabular roof, and where these lines interact is the alpha angle. The second is the inclination line or the cartilage roof line, which runs from the acetabular labrum to the bony rim. That bony rim is where the concavity turns into convexity, and the angle between the inclination of the cartilage roof line with the baseline forms the beta angle. So alpha and beta are angles that we need to learn to draw. The machines give those angles. Nowadays, most of the recent machines have the softwares where the most important part is first that you get the right section, and second, draw the lines in accordance to the anatomy, and the machines will automatically now give you the angles, calculate the angles. So the alpha angle is a measurement that is the most useful to help guide treatment. Even if you base your evaluation on alpha, I think that's half the job done. It is the angle between, as I said, the iliac line, the baseline, and the roof line, and it should be greater than 60 degrees. Now you have to understand that if I say that it must be greater than 60 means my acetabulum is perfectly very well developed. In a normal acetabulum or a normally developed acetabulum, I will not see the roof of the acetabulum because the roof of the acetabulum will be almost perpendicular to my transducer. So what I'll see is I'll just see the bony rim. I may not see the roof. The moment I start seeing roof and the roof becomes more and more prominent, meaning that the acetabulum is getting shallow. Imagine in this diagram itself, if I say that the alpha angle is decreasing, means that my roof line is coming more or less towards the baseline. So as my roof line comes towards the baseline, my acetabulum becomes more and more shallow, more and more maldeveloped. So if my alpha angle falls less than 60 degree, I am dealing with a developmental dysplasia of the hip. You can also see the femoral head coverage when you draw this line parallel to the iliac bone. It will find that the femoral head, the unossified femoral head, gets perfectly bisected by this line. In fact, the ideal section would be that 2/3 of the femoral head will lie inferior to this line and 1/3 will lie lateral. But it's perfectly bisecting, which is good enough to say that there is adequate coverage of the femoral head in the acetabulum cartilage as well as the labrum. The beta angle is the angle between the baseline and the cartilage roof line or the inclination line. It basically says that there is a good acetabular coverage. The beta angle again should not be more than 55 degrees. So what do I mean that if the beta angle increases? For example, this is 55 degrees, let's presume. If I say that my beta angle is about 80, that means my inclination line is more or less getting perpendicular. So it passes to the acetabulum. So if it is getting perpendicular, that means my acetabulum is getting displaced superiorly. And that can happen only with a decentered femoral head. So understand this concept well. If my alpha angle is decreasing, it means that my acetabulum is getting shallower. So I'm convinced I'm dealing with a deformed acetabulum. If my beta angle is increasing, it means that the acetabulum is getting pushed up, and therefore my femoral head is actually displacing the acetabulum up there. So the shorter version is purely on alpha angle, and this works well. If you want to stick to this, this works very well. You have type 1A where you have an alpha which is less than 60. You have 2A which is an immature hip where you have an alpha between 50 and 59. We will delve into each type and subtype for those who want to take it. But this classification alone is also good enough to begin with. Type 2 is when you have an alpha angle 50 to 59 beyond 3 months of age. And type 2 is when the alpha further falls down less than 50. Type 2D is when you have a decentering hip with a lower alpha angle. And type 3 is when you have a subluxed or an eccentric hip joint. And type 4 when you have a frank dislocation, your alpha will be much lesser than 45. So type 1 is an alpha angle which is more than 60, and these are considered normal. So normal hips are type 1 hips. That's how you typify them. A normal hip is a type 1 hip, more than 60 degrees alpha. Though there is a distinction between, mild distinction between type 1A, 1B. Type 1A depends on the beta angle, which is less than 55, whereas type B will have beta more than 55. But this is not clinical relevant because both represent centered hips. So this is type 1A, where you find that it is a well-centered hip joint, but if you look at the alpha angles more than 60, beta is less than 55, and therefore this is type 1A. Whereas type B, you will still have a normal hip, you will have a good femoral head. It's just that the beta angle would be slightly altered. You have beta angle slightly more than 60, and therefore it is categorized as type 1B. Now, type 2 is centered hip. Type 2A is physiologically immature. This is a normal feature for the first 3 months. It's called an immature hip joint, and it can slightly subluxate. It can slightly look eccentric, but this is an immature hip joint for the first 3 months of age. And therefore, this alpha angle may be between 50 and 59, but it's still considered normal for the first 3 months. But if it persists beyond 3 months, then it is categorized as a possibility of developing dysplasias, and it goes into type 2B. Type 2C is further going more eccentric laterally, and therefore the alpha gets smaller and smaller, and the beta increases. Type D is a proper decentered hip joint. So the two uh, types, the type 2 actually depends on the age of the infant. If it is less than 3 months of old, even if the alpha is between 50 and 59, it is considered an immature hip, and this is acceptable limit for that period of patient's age. However, if it is beyond 7 weeks, if it is still there, then that means that this is actually going into type 2A minus. So type 2A is actually considered an immature hip, and therefore we do not attribute more significance to it. We ideally call these patients back again after 3 months and reevaluate the alpha and beta angles to see whether they have normalized. So 90% of newborns with graft 2A hips do not develop dysplasias, and all we need at this point is follow them up and call them up after 3 months or 13 weeks. So if they still persist with the same angles, then there's a possibility that this type 2B can develop into developmental dysplasias. Type 2C is where this bony acetabulum starts getting obviously deficient to almost flat bony rim or a rounded bony rim. So the alpha angle keeps decreasing. The alpha decreases to less than 49 degrees. The femoral head is still fortunately covered by the labrum and the cartilaginous roof. And type 2D is when the hip starts decentering, and that's the only difference between C and D. Type 3, actually, I have just drawn angles to explain or objectify it, but type 3, the femoral head is obviously dislocated. If you look at this image there, this is the ilium, that's the acetabulum. It is deficient, it is shallow, it is quite obtuse there, and you find that the acetabular angle is also the acetabulum is also elevated there, and therefore the beta angle is increased. So this is a decentered hip. You will find that the entire femoral head is lateral and outside the acetabular cavity. So this is a decentered hip. The labrum is moving upwards, and as the labrum is moving upwards, the cartilaginous line or the inclination line is more or less following the labrum there, and therefore the beta angle increases. And therefore, I told you, if you understand the fundamental, it's easy to understand that because the acetabulum is pushed by the eccentric head, we are having a beta angle there more than 55 degrees. So in type 3, you have dislocated femoral heads and lateral to the developing lateral to the dysplastic acetabulum. Type 4 is a complete dislocation of the femoral head. In fact, here you may not see the anatomy at all. You may not appreciate the oscilium because you will have a lot of bony artifacts that may overshadow and obscure the anatomy. You will have the cartilaginous roof, which will be trapped between the femoral head and the acetabulum. and the acetabulum will also be displaced inferiorly. You see the overturned acetabulum there, and it is getting pushed towards the iliac bone because of severe lateral dislocation of the hip there. You will find this hip articulating with the ilium eventually because it is severely displaced. You see the acetabular roof, it is so deficient in whatever few centimeters you can see of it, and it is more or less getting parallel to the baseline or the iliac crest line there. So what we can actually do is we can do the Barlow's maneuver to see whether the head is dynamically subluxating out of the cavity. We do not do this for the first 3 months simply because in the first 3 months, the hip is immature and subluxation is known on dynamic maneuvers. We perform subluxations only beyond 3 months. And if you find that when you perform Barlow's maneuver, if you can move out the femoral head out of the acetabulum, that means there is subluxation and there's still a potential that this hip may land up with dysplasias later in life. So we often get patients who have been diagnosed, you have diagnosed, somebody else has diagnosed, and the orthopedic surgeon, the pediatric orthopedic has given a Pavlik harness and they come for treatment. So the goal of treatment basically for a pediatric orthopedic is to reduce and maintain the femoral head in the acetabulum as early as possible to allow the hip joint to develop normally. Remember the reciprocal relation between the acetabular head and the acetabulum and the femoral head. Unless both are coherent and joined together, both will not develop normally. And the whole objective of all treatment options is to get them together as soon as possible before they get deformed. And that is the sole goal, and therefore early diagnosis is important. And if you have diagnosed them early, so say for example, less than 6 months of age, the treatment of choice is an dynamic hip brace, the Pavlik harness that maintains hips in a flexed and abducted position. You remember the Ortolani test where we were abducting and flexing the hip so that the femoral condyle remains within the acetabulum. So we put the child into Pavlik harness whose sole aim is to keep the hips the way they described in the Ortolani test, abducted and flexed, so that the femoral head lies within the acetabular cavity. And the Pavlik harness is tried for at least 6 weeks for 23 hours a day. And you keep assessing the hips on Pavlik harness. And if you find that the hip is still decentered and has not come back or reduced within 4 weeks of it, you discontinue Pavlik harness and think of something else. If you find that there are a lot of erosions that are developing on the iliac bone, you stop it and think of somebody else. But generally, if you have picked it up early, a Pavlik harness success rate is close to 90% and works well in most patients. So you have this 1 month fetus there where you see that this is a grade type D dislocation where you have a flat acetabular surface there. The entire femoral head lies outside the cavity, and this classical type D type of dislocation. And this patient was put in harness, and you find that the femoral head now occupies the acetabular cavity, and you look at the bony rim of the acetabulum, you look at the acetabular roof, it has started developing well as compared to the pre-harness stage. The acetabulum has now started developing in response to the femoral head being within the cavity. That reciprocal phenomena has started working well. But there are times when we find that the harness does not work. Like in this case, that's the normal right view for you, and that's the abnormal follow-up 1 month in harness, 4 weeks after harness, we find that the head is still dislocated. So these patients come to you for follow-up. You have to ensure that you get the sections right and then give the relevant information to the clinicians. If the child comes to you between 6 to 18 months of old who has failed brace treatment, they probably go in for closed reduction and spica casting, and more than 18 months they go for open reduction. They go for osteostomies, and then the femur plate can be removed at a much later stage. But long-term follow-up is essential. Sometimes, as a residual dysplasia can occur 10 to 20% even after you have successfully done treatment for DDH. Occasionally, additional surgeries may be required to minimize the chances of early osteoarthritis. In DDH, what we are worried of is that late complication of osteoarthritis, and therefore additional surgeries the clinician may or may not undertake depending on his requirement. So a standardized report should be inclusive of all these parameters which are mentioned in the left: the bony roof, the bony rim, the alpha angle, the labrum position, the beta angle, the position of the head in relation to the acetabulum. Is there ossification in the femoral head? Is it symmetric, asymmetric? What do you see on dynamic stress maneuver? And the bony roof is described as good when you see it. When you actually don't see it, that's when it is good. When you start seeing it, the more you see it, the more deficient or the poorly developed is it. Normally, the bony rim is sharp, but in dysplastic hips, it can be rounded or flat. Alpha angle has to be more than 60. Labrum should be covering the femoral head. See whether it is displaced. If it is displaced superiorly, that means the head is getting displaced laterally. The beta angle has to be less than 55. If it is more than 55, that means that the acetabulum is getting pushed. The labrum is getting pushed. The labrum is getting pushed. I have been saying acetabulum all this while. Please pardon my ignorance. That was an honest, genuine mistake. The labrum is getting pushed, and therefore the beta angle has been increasing. The position of the head should be centered within the acetabular cavity, and ossification is very often delayed in a dislocated hip joint. Dynamic stress maneuvers are to be done only beyond 3 months of age, till 3 months. Remember, we have the type 2A hip. 2A hip is an immature hip, which is a normal hip. That's normal for that age. So try subluxation, dislocation, the Barlow's technique beyond 3 months of age. So conclusion, you should cite dysplasias on left, right, both type, and you can classify it by Graf's classification. You also have guidelines which were given by Pediatric Orthopedic Society. I think Dr. Nidhi, Dr. Bipin, and Dr. Ashwin attended this event in Mumbai, and they have actually laid down guidelines where a clinician should approach, and ultrasound does form an integral part. The first choice always remains an X-ray, but for the first 6 months, ultrasound is the modality of choice. So my take-home message is simple. Ask the age of the neonate. If it is less than 6 months, ultrasound is best to perform. But if you find that there is ossification of the femoral head, and by no means you can see the deeper anatomy, then ultrasound is definitely contraindicated. You cannot perform ultrasound because you do not see the lower limb of oscillum. So remember, again, reiterating the three anatomical sections: lower limb of oscillum, section to the middle of the acetabular loop that is parallel to the ilium, and the acetabular labrum. Always ensure that you get these three anatomical landmarks in your section, and that is the most important thing. So once you've identified the anatomical landmarks for line drawing, calculate alpha and beta angles and identify types based on Graf's classification. use triangles only for type 1 and type 2. As I said, type 3 and type 4 are decentered hips, and here you do not need angles to say that this is a decentered or dislocated hip. Access coverage of femoral head, especially on patients with Paulic harness, because the whole aim of Paulic harness is to get the femoral head in touch with the acetabulum as soon as possible so that both can develop as soon as possible. And if in 4 weeks it does not work, there's a good chance that it will not work at all. Ultimately, remember that motto, better ultrasound today than a limb tomorrow. Perform a good ultrasound and you save the child from a lifelong limb. Thank you very much.
Thank you, Mohit. That was a wonderful lecture. I really am
Very nice.
impressed. Yeah, very much. I think this was the best lecture on DDH I ever heard. Excellent graphics, excellent demonstration of the clinical signs and all. Very good, excellent.
Not only that, sir, he
Sir,
included the radiograph, which is
yes,
just
yes,
so
yes.
important
Important.
for the
Yes, sir.
radiologist to understand, because
Yes.
the radiographic, after a little while, it always helps, sir, because even if the
Yes.
ossific nucleus is not there, he gave the classification and the
Classification, yes.
lines in order
Lines,
to
yeah.
understand the subtleties. Very nice,
Yes,
Mohit.
yes.
Absolutely
Right, good.
thrilling.
Really,
Very
yes, yes.
nice.
Yeah.
So,
Yeah.
if there are any questions, anyone?
Yeah, I have a question. I think Dr. Mohit, I think, has covered it, but still, sir, this was a fantastic talk. I must tell you, I mean, it's really good. I'm glad I didn't miss any part of it. On I saw the first slide as well. Okay, so what do you see on follow-up scans? What do you mention? What is the thing that we need to look
So,
at?
first thing that you see is whether the femoral head is covered.
Mhm.
That's the first thing that you see. You look at the deformity of the femoral head. Look how the acetabulum has responded to the reciprocal phenomena. And we do dynamic maneuvers. Even when you have the child is in harness, we do
Mhm.
dynamic maneuvers to see whether it is still subluxating. But when you have a pre-harness ultrasound image with you, the comparison is striking. As I've shown you, you've seen that huge difference in the acetabular cavity once the Paulic harness has reduced the femoral head. The, the acetabulum, if it is very shallow, it will keep the femoral head out of the cavity. But once you've the Paulic harness has persistently kept that into the cavity, the acetabulum is now slowly developing. It is getting more and more perpendicular to your probe. Normally, your this is if this is the iliac bone, that should be your acetabulum because it is perpendicular. So you will see the rim, but you may not see the roof. That's the ideal situation. Okay, but in DDH, it becomes more and more deficient and more parallel to this baseline. So we'll always look at and we draw the angles all over again. We see the femoral head coverage. That is more important.
Okay. And so if you okay, so if you were to ask the patient for a follow-up, how much time do you ask? What is the
So
duration?
if it is patient is in Paulic harness, 4 weeks is mandatory. If it doesn't work, like in the patient where it didn't work, they went for alternatives. But ideally, if you are doing a neonate immediately after birth, you ask the patient to come back again after 3 months. Okay, because till 3 months, smile subluxation can happen even with the patient moving its, even when the child is moving the hip, you will find
Mhm.
that the head is subluxating because it's an immature joint. There's no strengthening, the soft tissues are still lax. So it still cannot prevent subluxation. So we do not include that as pathological unless it is grossly decentered. Okay. So we call the patients back again after 3 months, and that's when we actually draw those angles, see on dynamic maneuvers, and that's how we make a diagnosis.
Dr. Mohit, can I ask a question?
Yeah, Puchun.
Yeah. I mean, sometimes when the pediatric orthopedician sometimes just writes that, dynamic evaluation of the infant hip. So what are the dynamic maneuvers that we do? Just the ortolani and the Barlow maneuver, that's all?
What we are trying to see, we are not trying to reduce the hip joint. We are trying to dislocate the hip joint. The idea is to see whether the treatment options are working. So to see the treatment options are working, we have to try and dislocate the joint, and therefore Barlow's is useful. You adduct and give posterior pressure, and that's how you actually do induce dislocation.
Okay, thank you.
Boy,
I
do you
make a
have any?
comment?
Yeah, go ahead.
No, sorry, sir. Sir, please go
No.
ahead.
Yeah. No, I want to. Are you using any cradle or something for the examination?
I was actually planning to buy it then,
Yeah.
but I do not get so much cases.
Right. Right.
Whatever I have is my long-term collection. But
Right.
what I mean to say is the cradle works, but I generally prefer the parents holding the hip, and
Yeah.
that's about it. Alka ma'am does it with the pillows. That also works wonderfully. It
Yeah.
serves as an alternative, a good alternative to cradle.
नहीं sir, I totally believe that mother's lap is the best. ये
Yeah.
छोटे छोटे
Then-
होते हैं but इतना दम होता है इनमें, आप
Yes, yes.
dynamic scan कर नहीं सकते sir. They
No, they-
scream the hell off. So
They
it's
feel
much
the-
better if the mother breastfeeds and then you do the
Yeah.
procedure. The
Yeah.
cradles have not worked for me at all.
Right. No, because
Mohit,
I had attended Graf's program in Pune. It was like
Yes.
1.5 days, 2 days. What he teaches is just forward, backward, stop.
Yes.
And,
Yes.
and
Yes.
I believe he was very adamant about his procedure of doing
Yes.
the
Yes.
ultrasound. He said, don't look at the screen. Don't
Yeah.
look. Only just close your eyes. Keep your transducer in correct plane and just forward, backward, stop. And
Yeah.
you must get the image. And that's
Yeah.
what he taught in his workshop. I
Yeah.
want to ask one more. See, this is what we have described as a graph technique. There is
Yes.
another technique, Harkes or something. I don't know
Yeah.
whether which
Actually, there is an American technique. but,
American technique. Yes, yeah.
But I say, because like you, I did the graphs course, and
Yeah.
I found that much more scientific, and I like the fundamentals of alpha and beta angles very much.
Right,
Okay,
right,
I understood that if the alpha is getting smaller, means my acetabulum is getting shallower, and my beta is getting increased, means my labrum is getting pushed up.
right.
So
right.
it automatically became so self-explanatory to me that I understood that concept better, and it stuck with me. So I didn't go and
Yeah.
to confuse myself with some other technique.
Right. But
So
anybody
what
else is
might
using
be
American technique, or
I
do you
have no
have
idea. I have
no idea? What about Nidhi? Do you have any knowledge?
sir, if you remember, Harki was there with us in 2015.
Yeah.
Yes.
He
Yeah.
demonstrated
You are
that it
more
actually,
dynamic. You are
yeah,
more
it's a
into
dynamic
dynamic.
scan
Yeah.
with Barlow's maneuver.
Yeah.
Right, right.
Combining Barlow's with dynamic scan is Harki's technique.
Yes.
Right. Yeah, that's cool. Yeah.
So, but what I have seen before I go on to say that, Mohit, you have you haven't mentioned about pubofemoral distance, which today they say that's a very sensitive parameter, and then you don't have to do anything like let the child just move the limb, and if the pubofemoral distance increases, then you say that there is a subluxability present, and you can rescan. So, what's your experience with the pubofemoral
So sorry. Please
distance?
enlighten me. Don't know of this. I'm so
All right.
sorry.
So, pubofemoral distance is where you have the triradiate joint. So, you have the alpha limb coming, the one that you call os ilium limb coming down, and then there is a triradiate. So, from there is the pubis. You measure the femoral head from the pubis, and about 6 millimeters is the outer limit. And then you let the child just move the limb. And if there is a subluxability, you take the video cine clip, and wherever you feel that it grows beyond 6 millimeters, you say that this is a subluxable joint, and then you do a dynamic maneuver. I mean, this is something which is, I also practice it, and it's very useful, particularly when you have extremely lax ligaments versus pathological subluxability. It helps that
Sure.
pubofemoral distance.
I will see that in next case.
I don't know how much it helps, but it did help. Like it is kind of neat trick. It is a kind of red flag, which helps.
Ma'am, I would just like to add on this.
Sure.
I'm Gaurav here. For the
Hi,
pubofemoral
Gaurav.
distance. Good, ma'am. Good. Thank you.
Okay, go on.
Dr. Mohit, it was a wonderful talk, and you covered all the practical aspects of DDH. For this pubofemoral distance, I would just like to add, I attended Dr. Alka Karnik's workshop in this MUS conference workshop last year, which was at Hamdard. So she, hello.
Uh-huh.
Yeah. So she explained it that as the hip is dysplastic, as the beta angle increases and the head subluxates, the femoral head will go off the triradiate cartilage, and hence the distance from the pubic bone to the femoral cartilage, the cartilaginous head increases. So then she said that it's a very specific indicator that we can be more sure of that there is instability and there's subluxation going on.
Correct. It is just an indicator of subluxability. Correct.
Yeah, so she in her reporting protocol, she had mentioned about the pubofemoral distance.
Yeah.
So my question is, like in the follow-up scans, like sometimes, like when the baby comes in a Pavlik harness, so we need to evaluate in the follow-up with the harness or without the harness. One, and because there was one.
Unless the clinician wants to know how it is doing without the harness.
Okay,
so it all depends on the clinician's surgery. We do it with the harness to see that it is well within the cavity, and then they will say, okay, good, let it stay in the cavity for another 4 weeks. And when they come back after 4 weeks, he'll say, now you remove the harness and see whether it stays inside.
Okay. So routine, if a patient comes with for a follow-up, then we remove the harness unless he has specific.
As I said, that depends on what the
clinician wants. Like whether it is inside the joint, it is contained or not.
Yeah. So when you're seeing it for the first time, 4 weeks after the Pavlik harness, and it is well, you find that the alpha beta now return back to normal, the acetabular cavity is now getting concave. So they will ask for it to be continued for another 4 weeks and then reassess again. And at that time, maybe they will want you to see them without the harness to see whether it stays inside, because by then the soft tissues would have strengthened, become more taut, and are then less likely to cause displacement.
Right. Thank you so much, sir.
Gaurav, I'm going to come back here. And
yes, ma'am.
See, why would you want to remove the harness? No orthopedician ever says that you remove the harness.
No.
The orthopedicians say that you do it in the harness, and if it is centered well, they keep reducing the time of the harness that is put on the baby. So they let the parent be more without a harness, and then till the child stands, they keep the harness on to be absolutely sure that the acetabulum is growing with respect to the femoral head. A child normally starts standing by 9 months. They don't allow the standing. So it's never so. I have never come across an orthopedician who said, I want the alpha beta angles without the harness. I've never come across. In fact, abhi to ye hai, 10, 12 years ago, they used to have, Mohit, you remember when they used to put that plaster cast? They used to put that plaster cast on a baby. In fact, we would cut a hole in that plaster cast and do the ultrasounds to know whether the centering was there or not.
I remember.
Yeah,
yes,
so orthopedicians don't say that you take off the harness, just that if it is centered well, they allow many more hours of without harness to the baby, and then they send you back again with the harness, still centered. They keep reducing till the baby stands. So I don't know why would an orthopedician want without a harness, because it's still dislocatable till such time that the baby is about a year old, because that is when everything ossifies. You see, then you don't have the cartilaginous portion which can dislocate.
I mean, because yesterday a patient was there, so the
Yeah.
parents got the baby without the harness on a follow-up actually.
Oh,
And it
someone
was a
very
3-month
daring.
follow-up. Yeah.
Someone very daring, I must say.
Yeah, and they were traveling from Chandigarh. So
Uh-huh.
I was still confused whether to do it with a harness. But when I asked, so there was no harness with them. And
Oh,
so that was crazy. And there was another patient who was a post-septic sequelae, destroyed femoral head.
yeah.
And so for that patient, I always had a requisition to just check whether the head is contained or not. But even after a yearly follow-up, when it was contained, but after a year or so, when they removed the
It
cast, the head
dislocates again.
it was loose. Yes, it was
Septic arthritis is a different ball game altogether.
correct.
I have yet to find a follow-up septic arthritis which did not dislocate once the baby started walking. I have yet to find a septic arthritis. They all dislocate.
Ma'am,
Thank you.
can I just ask one question?
Yeah.
Ma'am, in literature, there is this D/D ratio, that percentage.
Yes.
I remember in one, I think I listened to a lecture of yours maybe a few years back where you
Yeah.
had mentioned that D/D ratio. So nowadays, do we need to mention that in our report, or
We're doing
measure
that.
it?
Mohit also mentioned what we call as a femoral coverage of the femoral head.
In this.
And FC has to be given. Why? Because see, these become like an indicator for yourself also for a very strong report where you say that the subluxability is reducing or not. So one is of course the angles, but it's just additional information that so I give femoral coverage area very regularly, and then side to side comparison of femoral coverage is even more significant. When you go side to side between symptomatic and asymptomatic, and it has a much greater importance after 3 months also, once you have the ospic nucleus and the centering of the line. So when the baby is active, taking the angles in itself is a very big jal. And the more confident diagnostic values you have, the more confident you are. So I take femoral coverage by the D/D.
Yeah.
Yeah. And now to
Even I
all
do
the
that.
machines,
I
I
just.
remember in my old machine, I needed to calculate. But now to all the machines have an inherent software there to calculate. Much easier.
Okay. Thank you.
Yeah,
Also,
good
Mohit,
evening, ma'am.
I'm sorry, there was
Amol
somebody
here.
asking a question.
Is
Amol,
it
hi
okay?
Amol, how are
Yeah.
you?
I'm good, ma'am. Thank you.
Good to hear from
Thank,
you. Go on.
thank you, ma'am. Thank you, Mohit sir, for such a great presentation. We got all the insights about DDH and graphs method and angle measurement. I just have, as you have mentioned, most of the times these kids are they're coming when they are diagnosed or some orthopod is suspecting DDH. But if we want to screen these kids, what will be the ideal age, sir, for this? Like before 3 months or 3 to 6 months? Which period we will be like
They
finalizing
will
for the
send it
screening?
to you before 6 months. So whenever they send it to you, if you find that it is 2A, you just have a repeat examination later. That's about it. But the idea here is to understand that once the ossification starts, the anatomy gets difficult to visualize. And therefore, you have to remember that the 3 anatomical landmarks form the crux of your measurements image, and therefore they have to be seen in every image properly, and only then can you draw the alpha and beta. So os ileum is important to understand. If you're seeing an os ileum, you can measure. If you're not seeing, once the head gets ossified, you can't measure, and therefore that window is necessary.
Okay, okay, sir.
To add to this, Amol, see, not many pediatricians pediatricians are aware, but not many obstetricians are aware of the fact what is the time. So they'll send you the baby whenever they get worried, and the parents get worried. However, the literature says not less than 6 weeks, not more than 6 months. So
Okay,
that is
okay.
the rule, because less than 6 weeks, there are still physiological circulating hormones, which will lead to the laxity of the ligaments. But as Mohit said, you do the ultrasound. If you find that it is physiologically unstable, you call them again for a review. But less than 6 weeks, nowadays I've started refusing. I said there's no point, because the parents get hyper, everybody gets hyper, you are getting hyper because there is a subluxability there, and particularly in female little babies. So less than 6 weeks is really not a very wise idea to do an ultrasound and say, come back again. So I just refuse. I say, come back in 6 weeks, we'll see.
Okay, ma'am. Okay, thank you.
Yeah, I agree with you, ma'am. I think according to the IAP guidelines or something like that, if it's a breech delivery, they recommend that the patient should be sent at 6 weeks for a screening.
Yeah. And we also follow IHDI only. I mean, even like for the x-rays and everything, I'm not following any tonus classification now. I'm following IHDI, which is even better. So yeah, IHDI says 6 weeks. Yeah.
If I'm not mistaken, Nidhi, when
Yes,
I
sir.
heard the lecture of Graf, he
Yes,
said,
sir.
you know, of course, that was maybe that is an old concept. He said in Austria, any baby born, breech presentation, female child, first child, before the baby is discharged from the hospital, they would do
Yes, sir.
the ultrasound.
Yes, sir.
So what were they looking at that time?
So
Or
that's a screening.
हाँ,
So sir, but वो
screening.
screening होता है.
Yeah.
तो screening के जो rules हैं ये वो a little
हाँ.
different than diagnostic.
Okay.
So when
So-
they say that you screen the child out and you see
Yeah.
if it is dislocating, not for
Okay.
subluxabilities,
Okay.
they are talking that you screen the child if it is a dislocation, which means we are already talking congenital type 4, type 3.
Okay.
Rule that out, because there is
Yeah.
no way on X-ray you will be able to rule that out.
Okay.
So they
That's
want
fine.
to rule out dislocation and higher forms of DDH
Okay.
for the lesser grades, which can be managed conservatively. Then you say 6 weeks.
Okay. Yeah.
मतलब उन cases में ना जैसे sir mother को भी
हाँ.
DDH था, you
Okay,
already
हाँ.
have a very strong family history that
Family
is
history
coming
of
through.
that.
Yeah,
Mhm.
then you have the breach, then you have a high risk baby there,
Baby.
a
Yeah.
single born, and you know that there could be a twin pregnancy है, तो उसके अंदर this baby was the second baby, not the first baby. तो वो
Right.
जो red flags होते हैं, they actually want to rule out grade 3, grade 4.
Yeah. Okay. So the purpose is just to detect grade 3 and grade 4, not
at the time.
time
वो
at
तो
time of the
होगा.
discharge.
Yes, sir. At the time
Okay.
of go, they want to
Hmm.
rule out the major
बोल
defect.
Right.
बोल बोल
Mohit,
Great.
any comparison that you had or you could have studies with the MRI? Anyone has any experience of MRI of DDH?
Yeah, some limited experience. We used to do that during our residency. Follow up the serial MRIs.
Achha, all right. It's very surprising, but I've been doing DDH for such a long time, but I have not found a single MRI of DDH, anyone getting it done. So I was very keen to know if they do it and why would they want to do it. Maybe because the X-ray wouldn't have it and they have those very high diagnostic
No,
suspicions.
another reason why they would ask for an MRI, or rather, they even ask you on ultrasound that can you see the ligamentum teres or the pulvinar, which is preventing, when they try and reduce the hip, why is it not going in?
Not getting reduced. I love it.
So they ask for this thing sometimes.
Yeah.
So this is out of the standard protocols,
Yeah.
and we try and look for it. If you
That's
if
a
you can see it,
fantastic
that's great.
answer. Hmm.
Ma'am, I
But then
have also,
if yeah,
ma'am,
go
I
ahead.
have also done like 2 MRs for this irreducible DDS, like Ankit sir is saying, to look for pulvinar hypertrophy and for ligamentum teres, whether they're interposing between the joint space
Who's
and they're
it?
not getting
I
reduced.
can't recognize.
Ma'am, Isha.
Oh, hi,
No,
Isha.
you
Yeah,
see
yeah,
that.
yeah. Of course. Okay, okay. There's a little bit of static there. Okay, you've
So,
done an
ma'am,
MRI?
yes, ma'am, 2 cases I've seen on MRI. And then they were referred because they were not able to reduce the DDH.
Yeah, yeah. Fantastic answer. That was Ankit.
Yes.
I'm
Yes.
sorry to interrupt. Can I just take your leave? I have something coming up.
Yeah, sure. All good?
Very sorry.
Are
Very
you all
sorry.
right?
Good, all good, all good, all good, all good. Absolutely all good. But I just need to go. Please excuse
Yeah,
me.
yeah, sure,
Yeah.
sure, Mohit. Thank you
Okay.
so much.
Thank you.
Thank
Thank
you
you.
so
Thank you
much.
so much.
It was
Thank you.
fantastic. Yeah, yeah.
Bye.
Take
Bye.
care.
Bye.
Okay.
Bye bye.
So, Isha, you were saying yes, and the reason was that there was an irreducibility. What was the age of the babies?
I don't exactly remember, ma'am. That was like 2-3 years back I did that
All
MR.
right. Okay, okay. So
But there
this.
was like pulvinar hypertrophy and the soft
Mhm.
tissue was interposing between the acetabulum and the hip joint because of
Absolutely,
which they were not able
absolutely.
to reduce it.
You know, just in case anybody comes across an MRI of DDH, do please put on the group.
If it comes next, ma'am, I'll
Yeah,
definitely do.
please. I would
Yes,
love
ma'am.
to see. I would love to see. Perfect. Upasana is very quiet today. Hi, Upasana.
Ma'am, I'm just listening.
Akshay, you're just listening. That's very nice.
That's why she asked.
Okay. Lovely. So if there are any other questions, otherwise we bid a good night.
Yes.
Yeah, I think so.
Okay.
Great.
Thank you all
Yeah,
for
all
joining
right.
in.
Thank
Thank
you.
you very much. Good night. Thank
you.
you, Ankit,
Bye.
for organizing it.
Okay,
Thanks.
good night.
Thank you, sir. Good night.
Good
night,
night.
everyone.
Good night, everyone. Yeah.
Thank you.